Good afternoon. Thank you. I'm Bob Blum, and I am the director of the Johns Hopkins Urban Health Institute. And it's a pleasure for me to welcome you to this, the first of three Urban Health Institute symposia over the course of this academic year. I'll tell you a little bit more about the symposia and then introduce today's speaker. Last year, the provost of the university, Lloyd Minor, established an all-university initiative around the social determinants of health. Some of you may recall the event that was held, the day-and-a-half symposium last spring. It brought together about 750 faculty and students, primarily with some community, but very limited community participation around the social determinants. From that meeting, there was a initiative that followed and that continues, and you'll actually be hearing more about that. But the provost this past summer asked the Urban Health Institute if we would take on facilitating the 2013 symposium, and we agreed to do that. The 2013 symposium will be held in April of 2013. In fact, April 23rd, 2013. Mark your calendars. It will focus on the social determinants of health with a particular focus on Baltimore and action. And the keynote speaker is Sir Michael Marmot, who led the Global Commission on the social determinants. And Dr. Tony Eiton will be a concluding speaker from the California Endowment. As part of that initiative, the Urban Health Institute has taken on a set of activities over the course of this year that focus on the social determinants, with a particular focus on urban health issues and with the focus on Baltimore. And as we have thought about who we should be inviting and what the various focal points should be of that work leading up to the event in April, there really is no one who has the kind of international reputation than Dr. Carlos Castillo. I would tell you that the Urban Health Institute has been hosting these quarterly symposia for about 5 years now. And Carlos is the first person from Johns Hopkins that we have invited. But we do so because he brings both a local and global perspective to the issue. His reputation around the world for work in urban health, his reputation around the world in metrics of social determinants is really second to none. So it is a terrific pleasure to have one of our own give this lead presentation. Dr. Castillo has a few initials after his name. He started out life as a lawyer, then proceeded to get his MD degree both in Mexico, came here to do his master's degree, stayed on and got his DRPH. So those of you who are in the master's program, you've got a long way to go to catch up, get anywhere close to Dr. Castillo. I would imagine somewhere along the line, his parents thought, when are you ever going to go and get a job? But But he did, and it wasn't simply staying in academia, though as someone who has simply stayed in academia, I don't know that I would say it was so simple. But anyway, for 20 years, he worked at the Pan American Health Organization in a variety of capacities. He is a senior epidemiologist with PAHO. He organized the first urban health conference in 2005, and he has been a mentor and teacher to all of Latin America in epidemiology. If I were to read his list of visiting professorships, I think there are very few universities in Latin America where he has not or is not affiliated. So it is a tremendous pleasure for me, Carlos, that you have agreed to be today's lecturer. Welcome.
Thank you very much. Good afternoon, and thank you very much, Bob, for this incredible presentation of my background. In fact, I feel myself that I am a public health professional that is quite interested in moving the agenda for a new public health. Then I will be very happy to share with you what has been some developments in the equity-oriented urban health metrics all over the world. And I want to include four major topics. First, to consider what are the global challenges that we are facing in general in the society, and why the World Health Organization decided to constitute the Global Commission for Social Determinants, and what the Global Commission of Social Determinants did in terms of moving the agenda of urban health, but also linking public health in the actually the policy agenda of governments. Also, I would like to introduce some of the work of the different urban health observatories around the world, the globe. All of them are working now in developing local and urban health metrics, and I will share you some of the debates, some of the examples, some of the uses of all these metrics. And definitely I am interested in sharing with you what is the vision from our team in terms of the future directions of measuring health inequalities in urban settings. The first thing that I want to indicate that we are facing tremendous challenges all over the globe. Two of them are very much related to our topic, is health issues and the rich-poor gaps. Those two are very important for addressing the public health needs of the populations, not only in developing countries, but now more intensively in developed countries. This is the economic pyramid of inequalities. As you could see here, basically 68% of people only have 4% of the wealth, and 0.5% of the population has 35% of all the wealth. Actually, 8% of the population has almost 70% of all the wealth. That gap in the economic inequality distribution has been creating tremendous consequences for the human development. I want also to share what we had done in the region of the Americas, particularly when we start discussing the importance of the social inequalities in the region of Latin America. This is the trends of the income inequalities in our region. in Latin America. And I want to stress how important was us to see the tremendous widening of the gap. Latin America is considered by the World Bank of the most inequitable region of the world, because we have the richest people and some of the poorest. In this graph, we will see that in the 1980s, we observed that the gap was reduced basically because the middle class collapsed. Then we call the lost decade in Latin America. And after that, you see that the gap between the poorest and the richest has been increasing every time. In 2009, Dr. Lee, the director in that time before he passed away, he decided to create the Global Commission for the Social Determinants of Health. He had just received the recommendations from the Global Commission of Health Economics. That commission was very relevant for the costing of public health interventions. And here he was very interested in pushing the agenda of health in the major political leaders of the world. And the work has been done by the Commission with 3 years. And the work was divided in what was called as knowledge networks. Knowledge networks were teams all over the world that decided to put the state of the art in different areas. The areas are here listed, like the early childhood development, health systems, measurement and evidence, employment conditions, globalization, and urban setting. I was privileged to participate in the measurement and evidence and the urban setting knowledge networks. These knowledge networks were instrumental for the Commission to gather the evidence, the information, and the status at the global level of those topics, and was very important for the synthesis of how was public health in those topics. As all of you know, in 2008, the Commission released the final report, and that report include 3 very important overarching recommendations. One of them I will be centered, that is the measurement and understanding the gaps and the inequalities in health. The last year in Rio, there was the World Conference of Social Determinants of Health that emphasized the work of the Commission, and many governments, including the United States, decided to include the social determinants of health framework in the work of the government. I want to move now into why the theoretical frameworks were discussed by the measurement and knowledge network in order to implement and discuss the importance of the new metrics. Michael Marmot was very interested in moving from the proximal determinants to the real determinants. The idea for him, and he called the causes of the causes, that in general, most of the work in public health has been by proximal and not distal determinants. And in that regard, he took the work of Dr. Acheson, the Black report, and then the Margaret Whitehead report. One of the most used theoretical frameworks is the one provided by Margaret. Margaret Whitehead has been instrumental in putting together the importance of seeing the proximal and the distal determinants as key for understanding the health in the populations. There are many other frameworks that are also incorporating the cause of causes, and all of them are instrumental, useful. What I want to indicate that for the first time was relevant to incorporate the social determinants in the quest and in the research projects. There are many models, there are many frameworks, all of them try to include the social determinants as part of the causal pathways that need to be recognized for two reasons, for the assessment, but also for action. Most of the ideas here is developing an assessment and metrics that will be oriented into action or transformation. In that regard, the Urban Health Knowledge Network was hosted by the COVID Center in Japan and mobilized many of the professionals working in urban health and developed this first framework that, again, the importance is to incorporate the idea that we need to measure and to have actions over the social determinants. They published two key publications. One that is Our Cities, Our Health, Our Future. That was the report for the Commission to deal with all the recommendations and the work that knowledge network did in urban health. And also was the hidden cities in that regard was very relevant to link with the Millennium Development Goals and to recognize that in many cities all over the world, these slums were critical, and we need to recognize, because even in measurement, the census, most of the times they don't count these slums. And we start recognizing that this is a critical aspect for our new metrics. And there has been a lot of work being implemented in forcing census bureaus and governments to include these slums in their statistics. As Bob mentioned, I was the coordinator of the first meeting of urban health in PAHO. In that time, I was the director of the Public Health Forum. The Public Health Forum for PAHO WHO was also the way as the World Health Organization tried to reach public health and academic institutions and civil societies. In this meeting, also, we were fortunate to have Chris Gibbons as one of our speakers representing the school. We were very interested in putting three main elements in the discussion of the urban health metrics. One, that we needed to have a very flexible system. In general, even at the global level, was the intention to develop a single metrics in urban health, is to develop like a GNP in urban health. Then was a large debate that what type of indicators will cover all the contexts and all the realities. And that was a very interesting debate that we have over the years. Then the decision was we need to have a more flexible system. Local urban metrics should incorporate the social determinants, but should not be identical. In that regard, I will show you part of that work. The second is that the information systems that were currently available did not have proper intersectorial information. We have the regular systems that were feeding the medical model and health information, but we were not disaggregating very well the information about transportation, education, employment, etc. Then we start exploring how all these social determinants could be, the indicators of those domains could be incorporated in all these metrics. And the other thing is that the metrics should be more directed to action. It's not only for research, it's for monitoring and for action. And those are the main considerations for the new metrics. Starting that process required very flexible institutions and platforms. And the idea was from the World Health Organization to start developing the concept of urban and public health observatories. Urban and public health observatories are main operational research centers that take all the etiological research and information and put it into action, try to make not an etiological study or research, but health situation assessments, health situation analysis that will allow the local and the regional authorities to move the public health agenda. One of the most complete and the most advanced observatories is the London Observatory. The London Observatory and 11 additional observatories in Great Britain have been moving the agenda of particularly the methods. They developed tools and methods that we are very happy to start instrumenting and using. The Baltimore City Health Department has been fortunate that they were able to use many of the tools of the London Observatory for the elaboration of the current Baltimore neighborhood profiles. And that development took a lot of work of experts and public health professionals that were working in the observatory in London, and also the associations of the public health observatories in Great Britain. Also, I want to notice that the UN Habitat is hosting the Global Urban Observatory, very important for our work in urban health. They are in charge of monitoring the health of the slums in particular. And this is a major challenge. There are many very interesting and important observatories from the Barcelona, Mexico, Bello Horizonte, etc. The University of Manchester and the University of Liverpool are working with us, or we are working with them, in the developing of the local profiles of urban health in Europe. They just released a month ago the 51st urban health profiles of Europe. Very interesting work, took 3 years for them to complete it. And all the tools and methods have been, will be available for our work. The COVID Center is a center of the WHO that deals and is the Center for Urban Health. That center, it has been very instrumental in moving the agenda of health metrics. One very interesting role of the observatories is pushing the government and the parliaments in implementing and sustaining urban health metrics that are oriented into the equity. And the last one was the slope index of inequalities in life expectancy, now is formally after 2009 in England. This is a major success from the London Observatory. These are the, some of the metrics and tools that they develop for our benefit, and obviously they are using for London and many other cities in England. This is the health inequality intervention tool. Here is different tools that will allow you to do the assessment, but also to characterize the type of action or intervention that you will be using. But also, they try to identify what are the equity gaps in the different areas of the city. These are the main agenda items from the Global Urban Observatory. And again, they are very much interested in the slums and the areas that are highly affected by inequalities at the cities. They already did a survey in 360 cities. They have already the profiles, and they had 40 cities in each region, and they try to understand the different contexts that are all over the world. Very rich, was very interesting, the work. UN Habitat is a very friendly organization and is very supportive of many of our projects. They also hosted a very relevant expert group in which they tried to recognize an index in the inequalities of the slums. Again, the idea was to recognize what information domains were critical for the development of the index. The Global Commission requested for the COVID Center and for the Urban Knowledge Network to develop a proposed new index, and that was the development of the Urban Health Equity Assessment and Response tool called Urban Heart. Urban Heart is a very basic index, has been now fully implemented in 500 cities, was tested in one city in different regions. In the Americas was in Sao Paulo, Brazil. The idea of the urban health equity is to provide tools for policymakers to make some changes and negotiation with other policy areas. It's not only health, but it's how transportation, housing, education should move the agenda. It's a very basic tool, very useful for some countries, and has been expanded in different versions. There is a prototype, there is the toolbox, and the training already incorporated in their site. This is recognized as a very friendly in recognizing the first step of the inequalities. Is also provide a very good reference of the type of indicators that can be selected for different domains. They use 5 domains, and from those domains, they are recommending the lowest of the indicators in order to be available for countries that have limited vital statistics. However, this tool has been tested and been discussed with mayors in different countries, and even in Sao Paulo was very instrumental for the mayor to understand the complexity of health. And currently also Brazil is very enthusiastically changing the information systems in order to include the social determinants of health in the routine collected information. I want to move now in recognizing how we recognize the health metrics in urban health and equity. The first thing is that we need to measure the differences. Equity and inequalities are different things, but we in public health and in epidemiology, we need to measure inequalities that are differences. But how we measure differences is very important. In the United States, originally, the law indicated that in order to do the analysis of the inequalities, you need to compare your groups to the average population. And that is a common way to deal with the measurement of the differences. But also the idea was to change that definition and not to use the average, but to use the extremes. Means what happens if we have the experience of the best socioeconomic group or the healthy group. And now we call that gaps. Gaps are recognizing the difference between the extreme groups, not only the difference between one group and the mean or the medium, but to the extreme. We call that health gaps. Health gaps are very relevant in the metrics. However, Marmot indicated that we need also to recognize the health gradients. Health gradients is metrics that allow us to see not only the difference between the extremes, but also to understand all the population distribution of any area. And in that sense, is our question from the methods is what type of comparison population we will be using. And that's also a discussion that was important for the DALYs and for many of the new public health metrics. And always we follow what has been the achievable health and health expectancy in the world. And for that, many of the metrics use the achievable life expectancy in Japan. As you see in the United States, the gaps has been, these are the gaps in life expectancy between the black and white, both male and female. And the idea is to see that the gaps persist. There is an increment in the life expectancy. However, the gap persists. This is an average life expectancy. When we actually develop the metric, we start recognizing that the mean is canceling actually the inequalities. Although we are observing the inequalities by the means, when we decompose the gap, we see that the extremes are very real. These are the epidemiology has been pushing to recognize what type of metrics will be very useful for recognizing the differences. And these are the ones that are highly recommended. I want to indicate that when we provide the profile of the inequalities at the urban level, we select at least 3 metrics. We could not use only one. And you need to have complementarity in division. Not single metric will be sufficient to understand the full spectrum of the inequalities. And we also select at least 5 health conditions. Then it's important from the perspective that no single health metric or equity metric will be sufficient to understand the complexity of the interaction between the social determinants and health. Avertible deaths now are a very useful tool that intrinsically the metric has already incorporated the extreme. In order to recognize what is avertible is using the usually the 5 areas or neighborhoods with the best health parameters, and we compare the rest of the neighborhoods with that. The relative index on inequality and obviously the Lorentz curve, or better the concentration curve, are very important metrics because allow us to communicate with the economies. Gini coefficient and Lorentz curve and the concentration curves are commonly used in economics and allow us to understand what is the percentage of the poorest people that has the maximum burden of any condition. We use it extensively and we strongly recommend it to use it. I want to give you the example of the prototypes in England. In England still are using the average of England to recognize The parameter, this is the median of all England. This is for the different areas, and what are the critical dimensions in red that need to be recognized by the health commissioner or by the health department, and addressing those conditions in a priority mode. The idea is to have more focalizing interventions to critical areas instead to do the same thing everywhere. This, why then, again, we need urban health metrics? First is because there is inequalities. We call inequalities in statistical terms the heterogeneity in health. And this is very important also to recognize that space is a very important dimension in explaining the inequalities or the heterogeneity. It's important to recognize that the basic epidemiology consideration of tools are person, time, and place. Person, time, and place, for the first time, we are able to combine all the variables in those three dimensions with new tools that are geographic information systems. Geographic information systems are not only for mapping, but for doing a very complex analysis or geospatial analysis, as I will be showing in a few minutes. There are a lot of segregation by socioeconomic conditions in many cities all over the world. This is not privative of the United States or even countries in Africa or Asia. We have that also in Europe. And the Observatory of Barcelona is documenting the tremendous inequalities that are in Spain. Place definitely is part of the dimension that need to be recognized for identify the urban inequalities. I want to move into some examples. This is the first one that I am showing, has no order. This is the work of the Observatory of Bello Horizonte in Brazil. We are very proud that the director of the center is a graduate from here, and she's working very hard in providing the academic and the scientific support to the city. The Urban Observatory of Bello Horizonte is an academic-based observatory, and they provide the support to the city of Bello Horizonte. They start doing in 2001, the first time that they develop a quality of urban life index. And this is very important because in Brazil, the civil society has a tremendous power. It's called participatory budget. Participatory budgeting is a process in Brazil that a large percentage of the budget of the city is not by the is not for the government. It's for the civil society to decide how to use it. It's not even its government, but the community groups decided what they will use the funding. This concept, in the beginning, they were very anxious if it will be working, and now is fully implemented in all the cities of Brazil. It's a very interesting example how the civil society participate very much in the decisions of urban health, and for helping this participatory budgeting process, the observatory did this index. They use 10 domains and 35 indicators as the first exploration, and then recognize in 80 neighborhoods where was the critical areas in which they should receive proportionally more budgeting to those areas. As you know, most of the formulas for budgeting is they use per capita. If you have larger populations, you have more budget. but this has been adjusted by the inequality and the risk characterization of the areas. Then you will have also more if your area has been more inequitable. The idea is to have a redistribution of the wealth in the interventions. This is showing you the area in which has the lowest quality of life. These are in the slums of the barriadas that are in the mountain. See the difference between those areas and the rest of the city. And you could also identify that this white is the worst, the greens are the best areas in terms of the quality. Then this area received much more interventions and funding. They also developed the health vulnerability index that are very much related to the social determinants. And here, the health vulnerability index allow them to recognize interventions and funding for some areas or neighborhoods of the city. This is done in Guadalajara, Mexico. They were asking us if the mayor did not have sufficient funds to address all the problems, and we combined 3 different indicators related to the social determinants, and we select and we document that if they have lower budget, if they will focalize interventions in these small neighborhoods, they will be resolving 70% of the problem of the city. Then you don't need to do everything everywhere. You need to concentrate in specific areas. All these metrics have been very useful for planning and for focalizing interventions at the city level. This is to show in Spain, that is a country that for many years has been receiving some of the best quality of life in Europe. And in the right, you have the deprivation index. And what the Urban Health Observatory of Barcelona, this observatory belongs to the municipality. Carmen Borrell, that is the director, actually has been working here several years before with Barbara Starfield. She showed that the same areas of high deprivation also has the high rates of SMRs for diabetes mortality in the city, indicating that the social gradient for the inequalities in the distribution of the diabetes mortality was very clear. In Porto Alegre, this was one of the first cities that disaggregated the information at the neighborhood level. And they were able to understand that cardiovascular diseases was not a problem of the rich, but actually was avoidable cardiovascular diseases was more for the poor population of that city. And first they map the neighborhood by the different domains and dimensions, and then they recognize the relative disparities in cardiovascular, cerebrovascular diseases and ischemic heart diseases. As you see, the relative disparity index allows us to compare the best to the worst, and that gap is telling us that the dimension is 3 times, almost 4 times the poorest, the premature mortality for those chronic diseases. That was very important because for many years in Latin America, chronic diseases were considered part of the transition, epidemiological transition, and that was for the richest. Actually, it's not. The poorest are the one with the highest burden of chronic diseases. This is the first attempt by the observatories of France to recognize as the London using the average of the different of Europe to recognize the different, how they rank the different cities. They are continuum, but now they are merging these metrics with the Liverpool and Manchester universities. I want to introduce one of the very interesting metric for urban environmental health that is called IMECA in Mexico. This is the first online system that is reporting at least 3 times a day the environmental conditions in Mexico City. This is important because depending of the ranking of the index, the city provide different interventions that are very drastic, like closing schools in some neighborhoods or not allowing additional cars to move. And this is a mega city. As you could imagine, to have online this is an example for the world. The Environmental Protection Agency has indicated that this is the best metric for environmental health at the urban settings. For anyone that will be interested, obviously you could see in the website, and is presenting, as I indicated, every day, several times the index. They also, the observatory of the UAM Iztapalapa, they developed an urban deprivation index particularly for Iztapalapa. Iztapalapa is an area very deprived and very difficult for the city. It's where have a lot of crime, a lot of inequalities everywhere. And the interesting part of the observatory, this observatory is academic, it's in the university, but is constituted by graduates and doctoral students that are from Iztapalapa. Actually, they are studying the doctoral program, and these are the first ones that the community allowed to collect data. Not even the police could enter in those areas. And it was very interesting because when I discussed with some of them, they don't have water, they don't have sanitations in their homes, but they are very eager to become, with the doctoral degree, in the methods in order to help the community. They are highly energized, and the community, because their families have been for so many generations, are accepting them. We think that that type of metrics will transform the possibility to work there. Conventionally, this is the way as the New York Health Department is characterizing the distribution of some of the diseases. They use quartiles and recognize what are critical areas that they would like to see if there are some environmental or other factors that are affecting those. They are more robust and more sophisticated metrics that I will be discussing in a few minutes. The Observatory of Juarez is an NGO that is also within the university, and is in charge of investigating and assessing the inequalities and the homicides of women. As many of you, if you have been reading the press, this is an area in which women has been killed constantly, and nobody has been identified the sources. This is a border city. There are many speculations that maybe somebody from another country that is coming and killing them. They are developing this monitoring tool in order to address actually the problem. These are called urban health observatories that are thematic. They don't work in general, they work specifically in the violence for women. These are more sophisticated geospatial statistics in which we have density concentration to recognize the hotspots. These are done for Kentucky to recognize crime areas that are very relevant to be monitored. These are basic metrics that we did for Austin, Texas, recognizing what are the inequalities and critical areas that need to be recognized. We did also for San Juan, Puerto Rico. That was very important because the Secretary of Health was an epidemiology. Actually, still is now is the state epidemiologist in Puerto Rico. We try to characterize the different health domains with the determinants, social determinants domains. Finally, I want to mention why we need to address also the health inequalities in Baltimore. Baltimore City is one of the cities most studied for many years. If you will see how many dissertation, thesis, and work has done, but there is no depository of all the information. And that's interesting because if we pull together all the knowledge, we produce knowledge, but has not been used. Knowledge is produced for publication or for the archiving, and now it's very important to, again, to recognize all of that information. And one first step was to develop the Baltimore neighborhood profiles. The very few cities in the United States has been disaggregating the information at the neighborhood level. That allowed the city to see first the tremendous inequalities. As many of you already know and maybe had see the news, the difference between the lowest, that is Pepperton Terrace Hall in Market 62, versus to Roland Park, we have 20 years of difference in a very short distance. But in the past, everything was recognizing the average, and we were canceling actually the inequalities. For the disaggregation, once that we disaggregate the information, allow us to have metrics that will recognize the level and the level of the inequalities and the dimension of the gap. This is a very important change. The school has been participating in this process. We have the second cycle of the profiles that were released this year. And one additional thing that we are doing is we are validating all the indicators and the information with them. The school participates in both cycles. Here is something that for many of you is awakening. You see Roland Park with 83, Baltimore is 72, the US in 1970, and you will see the three worst neighborhoods and see what happened with the Holy Market life expectancy and the expectancy of Bangladesh. Is the same. We have the life expectancy of Bangladesh in Baltimore. Obviously, this is not acceptable, but it's important to document how we will be minimizing the equity gap in those areas. This is the premature deaths. That is another very important metric. And see that the premature deaths are located in areas that are totally consistent with the different metrics that we had been using. Also, when we recognize the absolute gap is the difference between the best and the worst is 12.9 percentage, and the relative gap that is almost two times different, the best and the worst. But also we need to confront things that are critical. See, in 2008, the level of the mortgage foreclosures in the city, they were concentrated also in very poor areas. And obviously is affecting. Why this is important? Because equity matters, and equity matters here are developing some metrics in recognizing the foreclosures, but also the ownership of the houses by the community or the groups. And it's very interesting to see that from almost 30 years, those areas, they never had been able to own their houses. And that creates a tremendous determinant of health that need to be addressed. These are the density of foreclosures in 2009, very close to us, but you see that this density is affecting the poorest areas, and that itself is sending a tremendous message. And you see how many are abandoned, and the vacant houses and buildings is a fact that we need to address in our metrics. When I present this, in other countries, we don't have that problem because that's different. Even in Europe, they don't have that paradigm. This is the health inequality index that we did with all of these indices. This is the linear combination of all the indices. And again, the areas that were critical are the same. And currently now, the city is working with redevelopment of the area close to the Lexington market. And we are reviewing how, what type of interventions will be relevant to improve the health through interventions that are outside of the health sector. Now we need to see not only how the health system is being solving some of the health problems, but how transportation, housing, education will be addressing those problems. This is a very interesting way that we combine for the first time three conditions at the same time. Here we see the percentage of African in the population in the neighborhoods. And this is the median income. As you could imagine, that those that have the highest percentage of blacks, but also the worst median income have the highest mortality and health outcomes, has the worst. Then we try to see if it's the dimension of race or is the dimension of the socioeconomic determinants. In the past, we were not able to have at the same time three variables together to recognize in those neighborhoods what are the elements that are interacted, what is the synergy of those. We call this conditional mapping. It's a very important way to recognize the interaction of the social determinants at the neighborhood level. In conclusion, I want to indicate that it's very relevant to recognize that place, both and individual and group inequalities need to be included. The idea is that there are different levels, that the multi-level analysis is relevant. We also need to recognize that the metrics at the neighborhood level are for research, but also for monitoring. Means that we need to recognize how the changes have been achieved and for actions. The differences in the neighborhoods, as has been documented by the Global Commission, are not natural, are done by determinants that are amenable for interventions. Then we need to start linking policies that will address the social determinants and will have an impact on the quality of life. And there is a relation that I want to see that we need to take very seriously in the academia here, is getting the information for action and understanding that it's not a research for publication. It's for the civil society and the government to use for interventions. And that feedback is very relevant in the new metrics. By the way, new metrics are very relevant for two reasons. One, the current metrics in public health were developed by the paradigm of rural health, rural public health, not urban health. We didn't understand very well the characterization even of the behavior of people in cities. And most of the metrics were developed almost 80 years ago. Even life expectancy, the Statistical Commission is very concerned that we need to change the algorithm. We are taking a lot of weight in the mortality of 1 or less and 65 and over, but a lot of people are dying in the middle, particularly for AIDS, for violence, and we are not waiting. Why this is important, and we discuss it in the Statistical Commission, is because we are sending perhaps a wrong impression that the life expectancy is increasing steadily. In many countries, that stop is regressing, but also it's important to recognize that maybe the new cohort, the new generations will not be able to live the life expectancy that we have now. Then we need to have better ways to measure even the life expectancy. Another very important recommendation that we discussed in the different meetings of the urban health metrics is that we need to use more geospatial statistics to address these disparities. These are very robust mechanisms and statistics that allow us to differentiate the different social determinants, but also provide us better ways to communicate with policymakers. In my experience with hundreds and hundreds of ministers of health, they are not experts. They are, in general, generalists. They don't understand our epidemiology. They hate when they have these reports of 200, 300 pages. They never will read even one. But they understand and they like maps. Then if you want to convey to ministers of health, then 1 or 2 maps will have a very powerful effect. And I saw that every September we have all the ministers of health of the Americas in Washington. And for 20 years I saw them, how they address the information that we produce. All these glossy, beautiful reports, they throw it away. They want things that are easy to understand and useful for them. Then GIS is a critical way to document, to develop the metrics, but also to produce the information in a meaningful way. Other thing that is important, and we discussed that we need to have better standards and recognition of what is urban health equity. What is a proper definition of neighborhoods? All of these considerations, we think that everyone accepts them, but there is no consensus. We need to develop even the definition of what is urban health. There is a debate. Many people, they think that there is no a definition of urban health yet. Then there is a lot of elements that we need to discuss and to make sure that we start building consensus. We need also to build the linkage between the social and political context in many of the data that is commonly used, like the census. The census should be more oriented into the context of this political consideration. We think that even surveys should not be representative to the entire city, should be representative to the critical areas. If we dilute the representation of Baltimore as a whole, we will have pieces of everything. At the end, we don't have meaningful information for areas that are critical. And we need also new information systems. The information systems that we have now are obsolete, are too aggregated, too basic, that they don't allow us to incorporate the social determinants. And the interoperability of the systems, although the Obama administration had created a very good initiative called Health Data Interchange, that is, the Health Data Initiative is allowing us to have access to all the data sets that are in the government. However, it's very difficult to, because they don't have metadata, it's very difficult to bring the data. And this new information system is also for other sectors, like education, like housing. They need to include variables and indicators that will be relevant for monitoring the equity. And I want to emphasize a debate that recently in Brasilia was done by the director or the president of the World Health Inequality Conference. He is the president of the Fiocruz, that is the largest research and training institution in Brazil. By the way, they have a budget of at least $300 to $400 billion a year. It's a huge institution, very relevant for the country. And he indicated that we need to make sure that we include a health equity for all the people, not only the policy of health. Health will require to have equity in everything. And in that sense, they are pushing that we need to indicate a paradigm in which health is a component, but not to forget that the social determinants are very critical. From the future directions, I think that we need to develop better monitoring systems. And in that sense, inequalities are needed to be monitored, but also healthy conditions. Many times ministers, they say, I don't want you to talk about health inequalities. Tell me about how I will build healthy communities. And in that sense, give me indices that will also compensate and understanding how we will be moving the agenda of healthy people. In that sense, urban health has that a challenge. We need to develop assessment for addressing the inequalities, but also to provide metrics to address how we will be building the quality of life of the population. We try to recommend the use of basic synthetic metrics. We were not very comfortable with very complex metrics. In that regard, a linear combination of some of the different domains were recommended. Also, we thought that we should not have a preset of indicators to be used, but to leave to the city or to the urban area to select what indicators will be better fitting the domains. We are interested in the domains, like economic, demographics, education, employment, but not on specific indicators. Every indicator that is representing that domain within that urban context is the one that we are very interested. Also, we think that we need to recognize clustering, and geospatial clustering is essential to recognize if the space is explaining the circumstances of the inequalities. And for that, geospatial statistics are really very much recommended. Also, we need to have disaggregated the information. It has been very difficult for the cities to work with aggregated data. And the challenge of using a small sample areas has been recognized in all of our meetings. Fortunately, the Observatory of London has been moving into methods to address the problems of a small area analysis very well. And with that, I hope I will have the opportunity to answer some of your questions and comments. Thank you.
I think we have probably about 15 minutes or so for comments and thoughts, reactions.
Yes.
If you could, just 1 second, we have microphones and just be a little bit easier for everyone to hear.
Sure. The diagram that you showed comparing Rollins Park to, or Roland Park to Hollins Park, I thought was pretty powerful. If you look at the metrics that you provided, whether it's foreclosure or incarceration or IDUs or whatever metric of urban health you use, Hollins Park is probably going to be pretty low. So if you, in terms of recommendations that you may give to Baltimore City, how do you stack up those metrics in a causal way to say that, in fact, a sanitation metric is what we ought to target versus an incarceration metric? Those are the metrics that actually are most important when you give recommendations. Because I imagine that ministries of health, if you give them 5 maps, they'll be pretty impressed by that. But the question is still, which map is the most important?
Well, there are 2 ways to answer. One from the perspective of the academia is using evidence and tools that have been very relevant for etiological research. I always think in what determinant will explain the maximum of the problem. And it's very similar to the attributable population fraction. If I will be suggesting, and I will give you an example for malaria, factors that explain only 10% of the incidence, the malaria will not be controlled. And that's what we are doing in Brazil. Recognize the characterization of the risk factors, but seeing what is the specific effect. And for that, we use the concept of attributability. Attributability is a very powerful concept that deals with the causal pathways that we already know, and we apply for that. And we use also for the Millennium Development Goals monitoring. That's from the perspective of using very powerful epidemiological metrics. In terms of viability, you need to mobilize the civil society. The Global Commission recognized that governments now are not sufficient to move the agenda and to solve the problems. They need the civil society, they need the private sector. Now, the problems has been so large that if they don't participate, there is no way, even with a lot of resources. We need to mobilize the civil society. In that regard, even academia play a very important role. When you indicate, sometimes the solutions that we present as experts are not the ones that the community will accept. Then you go by selecting the second most feasible to be implemented. In that sense, it's a decision that use the evidence, but also the feasibility of the action. I don't know if I answer. Yes.
Thank you for that. It was a great talk. I just want to follow up on that a little bit. Have you seen in your work, in the Americas, somewhere where, okay, we've measured the inequalities, we have some decent metrics, and then taking it to whoever, we then put in place an intervention targeting a social determinant, and then come back at some time point and found a reduction or in that outcome or specific outcome. And what I'm trying to get at is it possible to quantify the amount of a health benefit that you would get for the reduction in a specific quantity of a social determinant?
Well, yes, the answer is yes, but it's for things that we already know. In Central America, for every 10% of potable water, we avoid 2 deaths of children, then infant deaths. Then, in that sense, we use the attributability, and water and sanitation is so easy to measure that's and in that sense, it's feasible to do in that way. When we are in a more complex interaction in which you have the pressure, let's put the example of obesity.
Right, good.
And then we need to recognize that obesity, you will not be transforming if you don't deal with the real social determinants. In that, we need to negotiate with the private sector, because we will take one part, but at the end, the source and the cause is unchanged. And obviously, I could tell you what is the percentage of the attributability that we will be achieved if we do that intervention. We are teaching now this here, is the public health scenario. What if we do that, knowing that we'll change only 2 or 4%?
Yeah.
But if we don't go to the causes of the causes, then we need to involve now the private sector too.
No, I agree. And one of the, following that, just this, so even if we go to the causes of the causes, I mean, one of the things I hear, it seems like, people will say, okay, I agree, we should do this, but I don't know how much I'm going to get out of it in reduction of obesity or cardiovascular disease or something else if I spend X amount of my budget on this thing. And that's what makes it challenging for policymakers sometimes.
But the problem is that policy makers, we think always as governments. The reduction of the infant mortality in the Amazon the government was very instrumental, but the important factor was the Rotary International and the Catholic Church. They worked intensively in improving not only the healthcare, improving the housing, employment, and those, if you see the dramatic change in the trend, is because of those interventions. Obviously, the government is part, but civil society, the elimination of polio in the Americas has been because of Rotary International, not the governments, not only the governments. Because when we always talk, thing is in policymakers in the government, but now we need to think what other members of the civil society will play a key role in making the change.
To follow up on that, Carlos, part of that is the short-term nature of, sort of like Wall Street with government. There's an election cycle, and so if you can't measure metrics within that, it's problematic. And he said, sometimes interventions are ranked based on what civil society would accept. I would posit to you that in America, unlike Europe, where government is afraid of civil society, it's the opposite. So what happens when civil society wants something, but government is not ready to bend to that, the power does not concede, and especially with short-term election cycles. What can you tell us about the wisdom of what needs to happen to move health equity forward in America, in the U.S., in that context?
Well, as they indicated in the elections, compromising is important. You could not move the agenda if you maintain the contradiction. There must be a common ground that will give you the opportunity to work towards. The speed of that's something that needs to be negotiated. Many interventions, sometimes when I see the amount of funding that is needed to put an agenda here versus other countries, even in Europe, the cost here is so high, and in other countries is maybe 10% or less to achieve the same. For some reason, everything costs here too much. And interventions in general, when we start thinking the cost is not the cost that here is needed. Even civil society here needs funds. Everything is with funds. In other countries, solidarity is so, people are sharing more. Maybe that's what it is. But compromising is important. And civil society, they are so fragmented. There are so many groups, and everyone is representing the urban area that they are competing. They are not joining forces. And that's part of the fragmentation of the civil society. I think one important effort is to bring the civil society working more together. Yes?
This year, the APHA, was on the social determinants, and they had very similar, advertisement. In this zip code, the average life expectancy was 63, and this was 82. So it was very much what you had already presented. But I was heartened that one of the keynote speakers was from Kaiser Permanente, and just as you're saying, the private sector and the civil sector need to get involved with this. They have taken that upon themselves and have found, and as far as prevention testing, so that they have eliminated their health inequities in HIV testing, and now they're going after mammograms and prostate cancer and all of that. So I do think they are understanding, there is some understanding that they're going to end up spending less healthcare dollars if they focus on the prevention and elimination of the disparity. So it's interesting to see it from a variety of different ways in the partnership.
Yeah, you are right. We need the help of the economists too. I will give you my experience in malaria. For many years, I was the epidemiologist in charge for malaria control in the Americas for many years, and I was very concerned that always the economics and the economic assessment was telling the best alternative and the best option and intervention is DDT spraying internally in the houses. But then I realized that was with 1 year, and then never the interventions that were environmental, eliminating the breeding sites, were included because of the cost. But if we prorogated for 5 years, the interventions that were very successful and very cost effective were the true ones, environmental. But we never took it because of the pressures. It was true that we have decreased the malaria, particularly because of the reduction of the mosquitoes, but the next year will be again and again. And that's something that we need to consider. What is the time frame for our assessments in order to be cost effective? Because if we say that in the conventional times, we never will have the right interventions. In general, the medical sector should start thinking not in the short term, but in the long term. I will give you one example. We finished 3 years ago the most important survey on diabetes in the Mexican-American border, 12 border cities in both countries. We did the assessment, and we recognized that almost 18% of the population had diabetes. But that was not only the problem. The problem is the pre-diabetic population that in 5 to 10 years will become diabetes. That was 25. Means that we will have 40% of the population with diabetes if we don't have the interventions now. And that's something that we need to understand. If we add obesity is a major problem for the survival of people. Do you think the life expectancy will be the same with all the obesity levels? No, they will start in a few years dying and dying. And that's something that we need to consider in our assessments too. And the private sector needs to reconsider many things. Yes. I'm sorry.
No, your mentioning of time was exactly what I wanted to refer to, that you talked about the dimensions of time and place and person. And as an aside, would like to know from you, with your historical work on Baltimore, I know that back as early as the mid-60s, the health department had transparencies that they could give me in order to establish a place for a family planning clinic. They could give me transparencies of the areas, the tiny areas in town with birth rates, with family size above 4, with violence, with life expectancy, with everything. And I didn't know whether in your historical work you'd been able to access some of that incredible material in Baltimore. But mainly, I'd like to understand how you are working with governments or whatever to establish using the same measurements in the same size and place over time, because I think the questions about evaluation of outcomes are totally dependent on that. But also, if there is a beneficial outcome, it's the only way that you will know whether it was some other change that had nothing to do with health access or anything else that made for that difference.
Thank you very much for the question. Fortunately, we have Sarah Morris here, and she's in charge of all the major data sets and planning and coordinating with EPI. They are doing a tremendous job in disaggregating the information at the neighborhood level. Never in the past was that visible. And I think very soon should be accessible to all of you. But the profiles are there already in their website. The second thing that you mentioned is important about how the governments will be doing the measurements. What we did is that we decided to evaluate the indicators that were available in the countries. We recognize more or less 5,000 indicators, but they analyzed like 8 or 9. Then we discussed the concept of core data. Core data are critical information that is needed for planning and evaluation. And we selected 170 indicators for that. And 12 years ago, we called the Core Health Data Initiative in the Americas. Now it's fully implemented. It's highly validated data. The government of Brazil invests only in the validation of these 170 indicators, $1 million every year. It's highly validated. And they are using for allocating funds, not only for the assessment, but if they don't have high quality, they don't receive funds. And in Brazil, the funds are given to the cities, not to the states. And the powerful secretaries of health are the secretaries of the cities, not of the state. And they will get the data, they will get the funds according to their data and the quality of the data. Has been very successful. I am very proud because that was recognized in Europe, and now this year Europe has their own core data too. The selection of those indicators that will be useful for monitoring and evaluation. The idea, Baltimore City Health Department is an institution that is also with limited resources. I think we need also to give, there is a lot of information here that we should also transfer to them. It's both ways, I think. Yes.
Thank you very much for your talk. I'm wondering if at all, are you seeing metrics of happiness coming into your work being factored? And I'm thinking of the work of it's like the New Economics Foundation and the Happy Planet, and and it's almost you can almost mock it in a way, but there are some serious scholars looking into this, and I'm just wondering if you're finding any of that in your work.
Yes, actually, yes. Satisfaction and quality of life doing into happiness. Now many people are, they start working with the resilience metrics, but now they found out that it's important to have within the mental health and The World Health Organization decided to launch a new classification that is of disability classification, that they changed the paradigm of understanding quality, and in which satisfaction and happiness are part of the new vision for them to be recognized, because happiness is very important. And
Sort of the end game. Sort of the end game, right? I mean, that's why we want to be healthy.
Right. We see that we have some difficulties in understanding the quality of life of elderly. I think that's something that we are pushing, because we need to recognize not only the life expectancy, but the quality, and their functioning will be important, but also happiness. Yes. Yes.
We have time for one more comment or question. I think Ernest had his hand
up. Thank you for your talk. The information was quite informative. And you spoke a lot about metrics and about the measurements, and you actually showed how they were being used in a number of instances. However, at the end with your recommendations, and I found that quite interesting, is that you recommended, I took down 3. One was about geospatial mapping, about generally accepted, and I wrote it as, you said measurements, but I also would put in the word terms. And then you mentioned a new IS, or information system for monitoring the social determinants of health. And I found that to be interesting, just because one of the things that has come out of your talk is that as we begin to look at this data, that we must begin to disaggregate it. And so all of a sudden, as we begin to go across regions, that becomes, all of a sudden, there's also we begin to see some changes across there, because you also mentioned gradient. And so in what way, or can you give a little bit more detail in terms of those 3 well, actually just around the recommendation around generally accepted measurements, because the GIS system, both the information system, will either be overwhelmed or governed by what happens right there.
Yeah, we discussed that one option is to recognize that sometimes non-conventional metrics will be useful for being developed at the urban local level. The meaning is that we should not be rigid in making prescriptions of the type of indicators, but we recommend domains. The message is that if we are interested in understanding the human development and the equality, or the process to health equality, we need to see how these causes of the causes, or the determinants, are being working in the real context. We think that the new surveillance systems should have that component. Our current information systems are very weak in that regard. We have very minimum information for the main domains. That is one thing. When we recognize metrics is ways to provide synthesis of the information, summarizing. And summarizing, sometimes we need to have very simple metrics, and sometimes we need to provide more understanding in the metrics about the attributability of one determinant, like one of the questions. How I will know if that intervention will work? Then I need to explore the attributability of that determinant in explaining the outcome. But the current information systems are very conventional, very weak. They are not being used for that. They are using for very basic monitoring, not monitoring of the inequalities. And that's not only my recommendation, it's the recommendation of our different groups that are working with metrics. Sometimes we don't need to have very sophisticated metrics. simple metrics will be sufficient. Other times we want to recognize the impact of some of the interventions, because perhaps the most important concept is that metrics should be action-oriented, means that should be used for monitoring and action.
Thank you very much. I'm really sorry, but if you, I know there are other comments and questions, but it is the end of the session. So I want to ask you to join me and thank Carlos for a very
Thank you. Thank you.